Okay, welcome everybody. My name is Paula Tusiani-Ang. I work for Emotions Matter, and I'm here to welcome you on behalf of our board of directors and our staff to our webinar with Dr. Aguirre on BPD and adolescents. Before we welcome our guest speaker tonight, we're just going to do a little bit of introductions. Emotions Matter is a 501c3 nonprofit organization founded in 2015 to support, educate, and advocate for people impacted by borderline personality disorder. We do this important work by offering educational workshops, conferences, peer support groups, advocacy initiatives, and more. For more information about Emotions Matter, feel free to go to our website at www.emotionsmatterbpd.org. And as part of our introductions tonight, I'm here with Sarah Rosenberg, who's one of our vice presidents from our board, and Melissa Ferdinando, who's also joining us from our board of directors, one of our vice presidents. And Joe Mancini, our new director, is also with us this evening. Welcome, Joe. We welcome you to Emotions Matter. And I'm going to turn it over to Sarah for our group guidelines.
Sure, thank you. So use respectful language in the group. We accept difference and promote acceptance, respect confidentiality, no photographs or screenshots, avoid assumptions or judgments about other people's experience of BPD, show kindness and compassion, avoid explicit expressions of self-harm or trauma, which may be upsetting to others, and your safety is important to us. If you express concerns about your safety in the group, we will offer support and share lived experience. If your emotions escalate, and we can't comfort you, we'll encourage you to reach out to your support system or consult with a mental health professional. And we have some disclaimers. BPD spectrum, we know that BPD is a spectrum disorder. Everyone is at a different place on the spectrum based on how the symptoms present and how it affects their thoughts, behaviors, and daily living. This is a safe place for all people, wherever you are on the spectrum. One person's experience of recovery does not represent all. And Emotions Matter intentionally uses the word recovery because we believe with support and treatment, people with BPD can get better. And our goal is to offer hope. However, we understand that not everyone identifies with the word BPD recovery. Some prefer living a meaningful life or managing our symptoms. We respect where everyone is on the journey and how each person defines their own narrative. Turn it back to you, Paula.
Okay, and we at Emotions Matter are peer leaders. Although we have a guest expert with us tonight, we at Emotions Matter, we speak from our lived experience. And so, again, if you need medical advice, we do ask that you consult a professional in your neighborhood or your local locality. And for questions and answers tonight, throughout the presentation, we invite you to use the Q&A for questions. When our presenter is finished, we will moderate questions through the Q&A and direct those questions to our presenter. Our presenter will do his best to answer questions in the allotted time, but if we're not able to get everybody's questions, feel free to email us after the presentation and we will try to get answers to your questions. We understand and value what everybody brings to the table here tonight, and we'll do our best with our 1 hour time frame. And at this time, I'm going to stop share, and it's with great pleasure that I introduce a long-term friend and supporter of Emotions Matter, Dr. Blaise Aguirre. We welcome Dr. Aguirre, who is a child and adolescent psychiatrist specializing in borderline personality disorder, to present this webinar on BPD and adolescence. Dr. Aguirre has been a staff psychiatrist at McLean Hospital since 2000 and is the founding medical director of 3 East Continuum of Care, an array of programs for teens that uses dialectical behavioral therapy to target self-endangering behaviors as well as symptoms of borderline personality disorder traits. Dr. Aguirre is nationally and internationally recognized for his extensive work in the treatment of mood and personality disorders in adolescents. He lectures regularly throughout the world. Dr. Aguirre is an author and co-author of many books, including Borderline Personality Disorder in Adolescence, Mindfulness for Borderline Personality Disorder, Coping with BPD, at Fighting Back, and more. He's a trainer and specializes in dialectical behavioral therapy, as well as other treatments such as mentalization-based therapy for borderline personality disorder and associated conditions. And at this time, with great pleasure, I would like to turn it over to Dr. Aguirre.
Okay. Can you hear me? Yeah, awesome. Okay. Paula, thank you so much for inviting me. It really is a blessing to be on with you. You've been such a compassionate advocate for the cause, and so I appreciate it. Thank you, Emotions Matter, and your team. I think before Emotions Matter was just you, and now you've grown so much. You've increased awareness. So many people supporting you. So thank you so much for this. So I was telling Paula earlier that I was teaching in Singapore and on dialectical behavior therapy, and I was in. I started with a case presentation on BPD, and this was to a group of what they call case managers in Singapore, and who didn't know that much about mental health. And somebody, they know some about mental health, they're sort of support staff. And somebody said, "Oh, sorry, I thought that this was on dialectical behavior therapy." I said, "It is." He said, "Oh, why are you talking about borderline personality disorder?" And I said, why don't you look up, I said, "Are you on Google?" He said, "Yeah." "Look up DBT." They looked up DBT, and it said dialectical behavior therapy. That was the first entry, is the treatment of choice for borderline personality disorder. I said, the two of them, when you have an adolescent who gets prescribed dialectical behavior therapy, they look up what dialectical behavior therapy is, and even when a therapist is unwilling to make the diagnosis, they very quickly find out about borderline personality disorder. So I trained in medical school in South Africa. I came to the United States and joined McLean Hospital in 2000. And I saw a group of young people who were struggling with what seemed very familiar to me, this concept of borderline personality disorder. And in rounds, I would say, this is a 16-year-old patient with borderline personality disorder. And then people would gasp and say, "You cannot say that." And I said, "What's that?" And they said, "Borderline personality disorder." I said, "Why ever not?" And they said, "Well, because A, you cannot diagnose BPD in adolescents, and B, we can't tell the insurance companies that because they won't pay for the treatment." And it was frustrating, saddening, because a lot of the people that I would see over and over again on the inpatient units were people with symptoms of BPD. So in 2007, with two other now retired colleagues, I said, "You know what? We're going to treat people with BPD, and we're not going to lock the doors. We're not going to strap people down. We're not going to give people injections." And DBT was a compassionate treatment, which I discovered at the time. I didn't know that much about DBT. And with their knowledge of DBT and my knowledge of BPD, we put together this unit. And we've had more than 5,000 young people from all over the world come through our program. And there was a hesitation, a strong hesitation, saying that somewhere between 10 and 15% of people would tragically take their lives. And so 5,000 people, that would be an expectation of somewhere between 500 and 750 people taking their lives. We're saddened by any loss of life, but we're aware of 20 people whose life has ended early, not 500 and not 750 people. So, we continue to be, very, very happy with many of the outcomes. And our treatment is not necessarily the end all and be all, but it is a step forward. And so with that, I want to just talk about this concept of BPD in adolescents. So just in terms of disclosure, I write lots of books. Some people actually buy them, some even read them. But my patients tell me that they're the cure for insomnia. So I do receive some royalties from various publishing houses, but what makes me really happy is less about the books, but more that many of them have been translated to different languages, including Chinese, and Mindfulness for BPD was translated into Arabic. And it took a lot of time because the concept of a mindfulness-based approach into a predominantly Islamic kind of part of the world. It was published by a Saudi house. Was difficult, but it was accepted. All right. So first of all, I started whenever people told me that there was this thing that happened at 18 when somebody could develop BPD, was very, very curious to me, because I said, well, but what are they the day before they turn 18? Are they, what are they? Do they not have BPD the day before they turn 18? Do they have to wait until they turn 18? And it also flew in the face of both my own personal experience, the experience of people with lived experience, and the research. And and I'd often ask people with adults with BPD, like, when did they first notice their symptoms emerge? And many said that they noticed their symptoms in adolescence. So the idea of having to wait until somebody was 18 to help them out seemed that to me that there was a lot of time where somebody would suffer tremendously until they were 18. The other thing is that personality evolves in children, and it's not as if there's blank slate until age 18 and all of a sudden personality develops at age 18. And if there are personality traits that are adaptive and effective, there's also personality traits that are maladaptive and less effective. The other thing that I was sort of surprised is that psychiatry had no problem diagnosing adults and children with ADHD, adults and children with anxiety, adults and children with depression, adults and children with autism spectrum, adults and children with bipolar. So why not, sort of a personality disorder? But here was the thing that was most sort of concerning to me, and that is, that people who suffer with extreme emotions, when they say, like, it's so bad that only self-injury or suicide is the solution, I mean, that we've got to pay attention to that. We've really got to pay attention to that. And people with anxiety weren't telling me that. People with ADHD weren't telling me that. Even people with significant depression weren't telling me that their emotional pain was so intense that only self-injury or suicide was the solution. So if that was true, and actually the data were bearing it out that people were tragically taking their life, surely this was something that we had to pay attention to. And megadosing people with psychopharmacology was not the way to go. Okay, well, I don't need to discuss this with a group of experts. The only thing is that I used to go to conferences and say the first person who shows me that BPD or an emotionally unstable personality disorder cannot be diagnosed in adolescence, the first person who shows me that gets $1,000, and people would rush off and buy the DSM. And no one ever cashed that check because the DSM did not preclude it. It just said that the pattern of symptoms has to exist for at least a year before making a definitive diagnosis. So if somebody who is 14, 15, 16, 17 has had symptoms for a year, that it is diagnosable. The other problem is that where a lot of mental health experts, so to speak, were having a problem was that because there are a minimum of 5 out of 9 DSM criteria, there are actually 256 different presentations of BPD. So if you can imagine that, you have BPD, and imagine that there are 255 other people with BPD in the room, in the hall that you're attending, every single one of them could have BPD, and all of whom could have a different combination of the symptoms. And so, it's sort of for say diabetes, a fasting blood sugar of over 100 is one of the criteria for making the diagnosis. But in terms of BPD, you can have all these other combinations. So this is, I think that this is, when I actually used this as a case presentation, I realized that most people with BPD don't have such severe symptoms. Many do, and certainly the people who come to my program do. But as Sarah sort of said, like it's sort of recognition that that BPD symptoms are on a continuum, and that many people don't have to have significant number of hospitalizations. But this was just somebody who. This is a compilation of many young people who come to our program, so it doesn't represent any specific one, but many would identify with the sort of presentation of the young people who come to get treatment. Often what we see also in people who are suffering with such intense and painful emotions is the capability, the intelligence, the talent. And this is true even if academics don't reflect the level of capability. And the other sad part about this to me is that often people who are talented in this way don't even recognize it themselves. There's this sense of disconnectedness. Drugs, alcohol, and romantic or sexual relations are often used as a way of emotion regulation. People often talk about a lot of self-loathing, which is not a DSM criteria. It's actually something that I'm working on right now. I really want to target the experience of self-loathing in people with BPD, because none of the treatments, none of the approaches have. They can reduce other symptoms like self-injury and other things like that, but self-loathing is one of the things that persists, and I have an idea about how to target this, but it's going to take some time to sort of evolve. But this idea of not really liking themselves, intense shame and guilt about these behaviors, and then also that when these behaviors are done, that they provide relief from intense emotions, and staff and my staff and other people just say how remarkably attuned people with BPD are to nonverbal communication. And I think that this is probably that because people with BPD have such remarkable sensitivity, that they are porous to other people's emotional experience, and this is partly mediated through the brain's mirror neuron network. So historically speaking, people saw behaviors of adolescents with BPD as, oh, they're just being kids, they'll grow out of it, or that they're just like a reflection of poor parenting, a blame condition. And, so many parents felt so blamed that they would just beat themselves up and they couldn't be the best versions of who they are as parents. And it's not to say that parents don't have a role and that the environment doesn't have a role, but very, very in the same way that few people with BPD wake up in the morning thinking, how am I going to make those around me's lives miserable? Parents with BPD also don't think, okay, how am I going to, parents with a kid with BPD don't think, how am I going to make my child's life miserable? But there's, this sort of transaction that sort of happens. And then there was the language that was being used, like promiscuity and manipulation, words that I'm a bit of a word Nazi in that way, because I do not allow those words on our unit. And that BPD was a condition that clinicians refused to treat. Now, so what does the research show? If we're going to be talking about this condition, what do we know? that it generally emerges during adolescence, and it looks like somewhere between 1 and 3% of community dwelling adolescents and 3.5% of young adults. Now, in inpatient units, this prevalence rises to nearly 50% of adolescents and 42% in young adults. And what is interesting about this is if you think 50% of adolescents on inpatient units meet criteria for BPD, but I remember being on inpatient units where no one was diagnosed as BPD. In the old system where they had Access 1, Access 2, Access 3, Access 2 was always deferred, which meant that a lot of people with BPD were just not being recognized as having BPD symptoms and not being treated. So efforts to avoid abandonment. So typically when people come to our unit, there's often rejection, especially a romantic partner, or rejection by a close friend or peer group. And in this day and age, sometimes that's even mediated through social media, where somebody wants to know where their friends are going. They don't know. They look on Instagram. Everybody's at a party. They haven't been invited to. They feel rejected and abandoned. This profound sense that someone essential to their well-being will never come back. And then we also sometimes see that suicidal and other maladaptive behaviors are sometimes reinforced by loved ones and caregivers when the only time that the parent, loved one, or caregiver shows up is when the person is really struggling. Unstable relationships. And these are characterized by, extremes of idealization and devaluation, and sort of the flipping back and forth between these states. And then therapists can often feel that they're being vilified, considered evil, or being idealized as well. And it's this reflection of all or nothing type of thinking that people with BPD, when they're in very significant emotional dysregulation, can sort of land in. I don't like this idea of splitting. Splitting is an old psychodynamic term that had its place and maybe does today, but it's often used as a judgment towards people with BPD on inpatient units, or they are splitting. That. And the irony there is that when I say to people with these very experienced therapists, you tell me they're splitting, are you saying that the 17-year-old with no psychological training is able to divide two experts who've got 30 years of training between them? So maybe you need to develop better skills if the person who's doing the bad action is the person with the least training. This unstable sense of self. It's harder to define in adolescence, especially adolescents with BPD, because adolescence is a time of defining identity. And, we often see people, whether they have BPD or not, kind of trying to define themselves, identify their own core values, their own sexuality, politics, ambitions. But we do see this enduring a profound self-loathing as some sort of core self-construct, and few things upset me more than seeing anybody but a young person with this core self-loathing. There's certainly sort of a degree of what I call emotional porousness, but because people with BPD, especially in adolescence, don't have a solid sense of self, they will often mimic or copy the behaviors of those around them and identify with that group, even if they don't feel they completely belong, because they sort of see that those are sort of accepted groups. So, but it's an even more powerful and painful way to be lonely when you identify with a group that doesn't actually speak to you and doesn't have a sense of understanding the suffering that you're going through. Dangerous impulsivity. Now in the DSM, we talk about spending money excessively and reckless driving, but you don't want to exclude that criteria because of you know, they don't have money or access to cars, but there is at times indiscriminate relationships, sometimes romantic, not always, but certainly drug misuse, eating behaviors, running away from home. And often these are there, you know, it's the dangerous impulsivity. It's not just impulsively, like I impulsively, you know, binge watched Dune the other night, but that's not the kind of impulsivity we're talking about. We're talking about impulsivity that's potentially really life-threatening at times. Again, recurrent suicidal behavior, and again, you know, a lot of self-injury and suicidality, and we've seen really very, very. These are not like I took, you know, 1 or 2 extra pills. This is, you know, unfortunately, tragically, people end up in emergency rooms. A lot of sort of self-injury, and what I try to, you know, like highlight to parents is that how awful must your life be? How much emotional pain must you be that this is where, you know, this is the only way that you see as out. Affective instability and extreme emotional reactivity. Often kids come in on multiple mood stabilizers, and it's not to say that people don't need mood stabilizers. I'm just saying that for core BPD symptoms, you don't need mood stabilizers. So people with BPD, adolescents with BPD, feel things quicker than their peer group, with apparently less provocation than others. You know, it's like, wow, why are you making such a big deal out of it? And they feel things very quickly, more intensely than others. And then when they feel very powerful feelings, it takes them longer to get to their emotional baseline. So if you have another insult when your emotions are coming back, then, you know, they will rocket up again. The other thing is, as I was saying earlier, like, you know, I've certainly found that people with BPD, I mean, they're very emotionally intelligent and other intelligences as well. But then when they're in a good mood, they can get a lot of things done. But when they're in a dysregulated or bad mood, the very same things that they could get done, you know, is much, much harder to do. Now, that's true of everybody, whether you have BPD or not. But sometimes this is so mood dependent that they'll just stay in bed and not do anything at all, for example. There's chronic feelings of emptiness. People have tried to define what this emptiness is, and there is some now research on emptiness, and it's really the lack of feeling connected, or it's feeling incredible loneliness, even in when surrounded by people. I often have parents saying, "What are you talking about? They're not lonely. They've got all these friends." But what people with BPD tell me is, "Yeah, I've got all these friends, but they don't really know me. They don't know my true suffering. I can, you know, go to parties and do all these things, but like, I'm actually quite lonely. I don't feel very connected to other people." And then sometimes they'll do these temporary behaviors that, yeah, reduce the loneliness because they're so intense, and it sort of takes them out of that space. But it's this feeling of aloneness, even in a group of a lot of people. Anger regulation problems. I think it's all emotions, but the DSM talks about anger regulation problems, verbal attacks, you know. Unfortunately, I find that in the media, this is one of the symptoms that, you know, that gets focused on, and sort of, you know, can give people with BPD like this just this terrible stigmatizing condition, and you know, sort of or stigmatizing kind of label to it. And I actually see very, very few. I mean, I see a lot of people with BPD who can get very angry, but the actual physical assaults that are described, I see very little of. And sometimes the verbal assaults are there, but they're often, you know, they don't tend to be short-lived, and people with BPD often feel a lot of guilt and shame, adolescents, when they've been rageful or angry, especially towards the people that they love. Paranoia and dissociation. Again, people with BPD are at risk of developing PTSD, and traumatized adolescents are certainly at risk for developing BPD. Now, trauma is neither necessary nor sufficient for developing BPD, but it certainly doesn't make things any easier. We also need to differentiate BPD from complex PTSD, which can look, quite similar, especially in adolescents. We certainly see dissociation and depersonalization and paranoia. Now, these are some of the other criteria that I see in the kids that we treat. This sort of see themselves as loathsome, a lot of self-loathing, a lot of self-hatred, evil, contaminated. This profound sense of hopelessness, and it's not the kind of hopelessness that we sometimes see with depression that kind of lifts when the depression is treated. It seems somewhat more enduring. This is another symptom, this marked lack of sense of continuity of time. Like, people sometimes say about people with BPD is like, oh, they're just lying. That just didn't happen. And it's when you're suffering, time seems eternal. So that if you have like the worst toothache of your life, and say it only lasted 10 minutes, and I come and I say, hey, how's it going? How are you doing? And say, I've got this terrible toothache. It's been there for hours. When you're suffering, it feels like it's been there for hours, even though it might only have been there for 10 minutes. But when things are going well, it feels as if it just lasted for a second or so. And but very powerful emotions distort the sense of time. And so it's not that people are lying, not to say that people with BPD don't lie, just like anybody else can lie, but it's just like when you're suffering so much, like, and people say, well, no, when did this happen? And when did that happen? Like trying to tell a coherent story and remembering like the order of things can be pretty distorted. Again, difficulty in performing despite ability. I've heard people say, oh, my child isn't gay, my child isn't bi, etc. And what kids say is, I don't identify in these binary or non-binary ways. I connect emotionally, I don't connect by anatomy. So even if they identify as heterosexual, it's like their love interests are not necessarily based on anatomy per se. This complaint of being universally misunderstood, and in fact, or that they don't feel to be misunderstood. And actually, when they explain themselves, I can see why they would feel that way, because people don't tend to understand, people with BPD. Okay. Right. So let me just see the time. So what does the research show about the developmental precursors to BPD? Researchers have looked at internalizing contributors. Now, internalizing is the stuff that happens inside of you that aren't necessarily visible to other people, which is, I've had so many people with BPD say, I wish I had a broken leg, or like something like an X-ray that could prove something, or because then people would see how much I'm suffering. And but these are the internalizing contributors. And then there's externalizing contributors, so like high novelty seeking, impulsivity, lack of constraint, and then there's childhood traumas. In retrospective studies, adult BPD is associated with childhood externalizing behavior. So often we'll see like people are called oppositional defiant and conduct disordered and ADHD. A few studies have actually tested the heritability for BPD. This was an important one for John Gunderson, who's now passed, but he said that somewhere that BPD, that the heritable factors of emotionality and temperament, somewhere between, it's probably somewhere around 40 to 60% of a person's kind of emotional system and ability to regulate that is genetic. Certainly ADHD is a risk factor for BPD, and ADD, especially in people who identify, for women, because often women with ADD as opposed to ADHD are not as disruptive in class. Teachers often don't realize that this ability to pay attention is really compromised, and so they are often invalidated in classroom settings and in other settings. This was just a study, an interesting study of 2,510 twins, a twin study, and then BPD was assessed from age 14 to 24, as well as all the internalizing and externalizing measures. And so what happened is that BPD changes throughout adolescence. Like, people seem to have like more definable based on criteria BPD early on, and then as people approached 21, 22, 23, it sort of dropped off. But obviously, given that about somewhere between 2 and 6% of the population have BPD or traits, I think that this drop off that we're talking about has only got to do with externalizing behaviors. But for people with lived experience, I mean, often, and especially when many aspects of their life has sort of come together, one of the things that happens is that the internalizing behaviors, especially things like self-loathing and negative affectivity, low grades of depression, still persist. And internalizing symptoms seem to have especially strong effect on adult BPD, especially when, so if a kid from 11 to 14 has a lot of negative self-talk, a lot of self-loathing, a lot of low, what we would call self-esteem or self-worth, that has especially strong effect on adult BPD. And I think part of the reason for that is that when you spend a lifetime talking negatively about yourself or being told negative things about you, and you internalize that, it's very, very hard to shake. All right, so what are the treatment modalities for BPD? But before that, what are the impediments to treatment? The truth is that adolescents with BPD commonly seek help, but the opportunities for earlier intervention are missed. And that's in part because clinicians are often consider it controversial to diagnose personality disorder in adolescents. There was a recent report in, I think it was the New York Times, that the trending hashtag in terms of mental health on the new DSM, I don't know if people know the new DSM, it's called TikTok. Well, anyway, on TikTok, the hashtag BPD was more than 2 million. There were 2 million. The 2 million entries were hashtagged with, I don't know much about TikTok and other things, but there were 2 million mentions of BP, 2 billion, which was more than anxiety and depression combined. So often what will happen is people identify with BPD, or at least that they identify with some aspects of BPD, and they'll want help for it. And when they go to their clinicians, they say, you're too young, you cannot have a personality disorder. And then people discourage, look, don't go so fast to making the BPD diagnosis. And so what happens is that people suffer quietly, and then because of the clinicians' reluctance to make this diagnosis, there's these iatrogenic effects, which means that because of clinician lack of responsiveness or neglect even to the diagnosis, a lot of the patterns become entrenched. The other thing is that there's something about treating adolescents with BPD that seems to cause more of an impact of sort of stress than maybe treating maybe an adult person with BPD. And I think, especially for some of my therapists who've got young children, I think that because the young people who come to our treatment are young, I think, sort of in the therapist's mind, it's just sort of like, oh my gosh, like these kids are suffering and my children are not that much younger. And I mean, I don't know that that's true, but and maybe also that we certainly see levels of self-injury and self-destructiveness that are that even though people with, obviously adults with BPD can be diagnosed with the condition and are, that the level of suicidality and self-injury, or the frequency of it seems to be really higher than in adults. So there's only been one study that compared a manualized treatment to cognitive analytic to manualized treatment which is called cognitive analytic therapy, to treatment as usual. And in this, so it's a really interesting form of therapy. It was developed, it was modified for adolescents by I think Dr. Andrew Chanin in Melbourne, Australia. And what he did is he compared that to treatment as usual. And at 24 months, patients in the CAT group had lower levels of and significantly faster rate of improvement in internalizing and externalizing psychopathology compared to the group who received treatment as usual. The CAT group showed substantial reduction over time likelihood of what they called ongoing parasuicidal behavior incidents and of even developing BPD. And now I think the same would be probably true of the treatment I use, dialectical behavior therapy. But that study hasn't been done to see if early intervention would prevent the development of BPD. But this is the one study that did show that development of full-blown BPD could be prevented, which was really a very interesting study. And Andrew Chanin is a thought leader in the treatment of people with BPD, is a very compassionate psychiatrist, and his team, I've met with him quite a few times. So when you're looking for therapy, what should all therapies that work do? The first of all is to understand the way that you're suffering in your own world. And I think that many clinicians sort of dismiss an adolescent's experience, will often speak with parents rather than with the adolescent. And it's like, for me, it's like, I want to know what the adolescent's experience in the adolescent's world. All good therapies try to make the person feel like they're understood. It recognizes that how someone gets to be who they are makes sense given their circumstances. That although that their life is understandable, but you still need to work on solving the problems at hand, help people recognize that conflict is part of life, that certain behaviors are choices, and as difficult as it is not to do those choices, that alternative choices are an option. And also that, people often say that DBT is very cold and robotic because we have no relationships with the therapist. But I just think that, I think I have closer relationships with some of my patients than I have with some of my acquaintances, because when you've really dug deeply into a person's suffering, you've gotten to know them very well, and the transaction that happens over time, and it is crucial. I mean, you're not going to put your hands in the hands of a pilot who's just learned how to fly. You want somebody with a certain degree of experience that you can trust, and that trust does develop over time. So these are the many different kinds of therapy for core BPD symptoms. To date, there is no compelling evidence for any medication that helps core BPD symptoms. Now, it is also true that a lot of people with BPD struggle with lots of comorbidity, and certainly medications can be used for those. In adolescence, the most robust research by far is in dialectical behavior therapy. Now, I would say if somebody's going to go into treatment, any treatment has to do the following. First of all, enhance the client's capabilities. One of my clients is an absolutely excellent artist, and I think that that's one of the things that brings her joy, and that should be enhanced to the extent that we can enhance them. It should be and sort of drawn out and used that bring her joy. Improve the motivation to change. So many adolescents say they do not want to change, which makes no sense to me because they actually do want to change. But often the reason is that parents come in and tell me, my kid has to stop smoking weed and have better partners and have better friends and all of that. And that's nothing to do with the adolescent with BPD's goals. They want to suffer less and be more emotionally regulated. So the motivation is often working on what the person wants to do rather than what other people tell them that they want to do. Ensure that new capabilities are generalized from therapy to the person's everyday life. It used to bother me a lot when my colleagues, before I started through East, would say, "Oh, the patient has gotten so much better." I said, "Yeah, because we've taken them out of their ordinary life, and now they have to go back to it. How do we know that what they've learned here is useful in their everyday life?" And often it wasn't. So whatever they learn on our unit, whenever they learn in treatment, has to be something that is useful, not just in treatment, but also outside of treatment. Therapists have to be better at treating BPD, and we have to reduce the stigma. That is 100% on the mental health community. They were the ones who started the stigma, and they're the ones who need to end it. And then, but psychoeducation also for the therapist, improve their motivation through new knowledge. Structure the environment. That sometimes I will advocate. Look, I'd rather that my patients be able to do everything on their own, but sometimes I will sort of assist them, like if they can't do it on their own until they can do it on their own. I don't know that necessarily, Paula, people can have these slides. I don't know that we necessarily have to get into DBT unless people want an overview of DBT. The only thing I would say is that that adolescents in particular really take to DBT more than any other treatment, because if I start talking about transference and countertransference in my adolescent sessions, they'll fall asleep within a few minutes. But when you're starting to teach, the actual skills and say, look, you are suffering emotionally. I'm going to teach you emotion regulation skills. You're having difficulty in your relationships. I'm going to teach you interpersonal effectiveness skills. You have a very hard time tolerating distress. I'm going to teach you distress tolerance skills. And you spend your life suffering in a future that doesn't exist or a past that's bygone. I'm going to teach you mindfulness skills. It makes more sense. So I think that adolescents in particular really, and again, not everybody, it's not like, DBT is some sort of panacea, but I'm saying that it is better than most of the other ones at getting to the core symptoms of that adolescents with BPD present to us with. And I can send these because I think that many people here probably have done some level of DBT, and maybe last thing that I will end with is I love this quote from Michelle Toomey, that words can inform our mind, caress and comfort our feelings, excite and thrill our spirit, and warm and kindle the flame of our hearts. They can also slap our face, punch us in the stomach, rattle our nerves, kill our desire, and destroy our self-confidence. And so when we use non-clinical terms like manipulative, attention-seeking, gamey, promiscuous, acting out, even the very word borderline, is that we do a tremendous amount of damage to people who are already feeling kicked to the curb and feeling sort of really down. And I challenge both the parents I see and the therapists that treat people with BPD, adolescents with BPD, to be very clear with me what they mean by using these terms that are not only non-clinical, but actually very hurtful and perpetuate a poor sense of self. And I've said, like, show me one place where the term manipulative, like, is seen as a positive. and it just isn't, so that's the one very important thing. And then the other thing is that it's taken often 14, 15, 16 years to develop for BPD to start evolving. So it's not going to change like here's my kid, fix my kid. The other thing, it's going to take time. The other thing is that because people with BPD are sensitive, strong emotions beget strong emotions. And you can co-dysregulate, but you can also co-regulate. So that if you bring your own strong emotions, and by the way, I make this mistake all the time. So it's not like, you have to be some sort of Zen guru to treat people with BPD, but you've got to recognize that when you've got strong emotions, which we all do, that's going to elicit strong emotions in somebody else. But in the same way that you can have strong emotion, it can also lower your emotional tenor. So that's, I think that's about that. I wanted to leave enough time so that people, who had questions could ask me questions about adolescent BPD. And with that, I'll, pardon me, I'll turn it back to this moderating panel.
Great. Thank you so much. That was so informative. Thank you so much for all the work that you've done, Dr. Aguirre. Paula, do we have time for a couple of questions?
Sure, go ahead.
Okay. So one question says, can you please explain how parents or caretakers contribute to self-injurious behaviors?
Yeah, I don't think that they do in a direct way. It's not like they're saying, okay, here, self-injure. But I think that over time, I think let's imagine that a parent says to a kid, hey, you're making a very big deal out of this very little thing. Now then maybe they have two kids, and one says, yeah, I'm making a big deal, and then they go on and they play, I don't know, shoots and ladders, whatever they do next. But for somebody else who's ultra sensitive, that's a real painful rejection of their own internal experience. And we would call that in dialectical behavior therapy invalidation. And when people feel invalidated, it leads to incredible emotional pain. And what happens is if you don't know how to resolve that emotional pain, you want a quick way out. One of the quickest ways out is through tissue injury, like self-injury, because what we know is that tissue injury causes endogenous opiates, or like your own brain's own morphine system, to release chemicals that actually reduce the amount of pain that they're experiencing. So it's not that they're causing self-injury per se. All they're doing is that in that moment, they're causing the condition where somebody's suffering so much that they just want out of suffering. So that's what I would say about that.
Thank you. Go on to the next question. They say, I'm curious if the issue with splitting is the implication of manipulation. How would you frame what might have previously been labeled manipulative behaviors in the past?
Brilliant. Okay. So here's the thing is, first of all, effective manipulation, you don't know you're being manipulated. One. Two, I don't know why people would manipulate their way into hospital. I say, if you want to be in the hospital all the time, become a therapist. But the thing is this, and that is, people do what works. Okay, I get into my car. I push the button. These days, before you used to turn a key, I push the button and the car starts. The car is doing what I want because I'm pushing a button. Now, if every single time I push an emotional button, people respond in a certain way, then I'm just doing, that is classic behaviorism. You give your dog a treat, your dog responds. Classical behaviorism. You could say you're manipulating your dog. Now, if people, like, we're constantly manipulating each other all the time. It's just that, why should I label manipulation that I don't like manipulation, and manipulation that I do like something else? And but this concept of splitting is a very important one. The old idea was that people had this concept of an unconscious concept of a good self and a bad self, and they would then send the good self onto somebody else and a bad self onto somebody else, and say, that's the good person and that's the bad person. That was the division. And I just think of it as polarizing behavior. And the other thing is this, is that I had a mother who said to me, like, I don't know if DBT helps. I sent you this terrible manipulative kid, and all you did is you made her a better manipulator. Okay. You know what, if somebody is better at getting the things that they need, I'm all for that, because we're doing it constantly all the time. And they say people are manipulative, you know, then go to Congress. I don't know, something like that. I mean, you know, so talk about the biggest manipulators on the planet, and people with BPD are just not. And I really dislike the term. So something like that. Sorry, I could talk for manipulation for an entire hour if you wanted me to.
Thank you. I'll do one more. Could you
say
talk
I
about the
personally
chicken egg relationship between BPD and ADHD in terms of the treatment priorities?
Perfect. Great question. Okay. So first of all, I would, you know, people say don't give people with BPD stimulants. They're going to abuse them. They're going to sell them. They're going to do all these terrible things with them. Now, so here's what happens. Let's imagine a kid is at home with ADD, and the parent comes in and says, clean up your room. And the child cleans up their room. The next day, the parent comes in and says, clean up your room. But the child has ADD and doesn't attend to the parent saying, clean up your room. So they carry on doing what they're doing. And then the parent comes in and starts yelling at them. And I said, I told you to go clean up your room. Like, what the hell, you're so lazy, or whatever it is. So now the child says, wait a second, why are you yelling at me? He said, well, yesterday you cleaned up your room, and today you didn't clean up your room. I said, well, you didn't ask me to clean up my room. He said, yeah, I did. But they weren't paying attention to it. So what happens is that because of inattention, there's increasing invalidation of the child, and the child is then getting punished for not following rules that they never did in the first place. So these days, I very aggressively treat ADD, and I, you know, no one's ever misused the stimulants. You know, month they come back, and so if ADD is at play, but I think that inattention leads to invalidation. The child doesn't know what to do, can't focus, can't pay attention leads to further invalidation, and so on. So I think it's worth to aggressively treat ADD. And Sarah, what I was going to say is, like, I personally, this is so important to me, I'm happy to stay on longer to answer people's questions if that's something that would be useful. I know that you may have to end, Paula, so it's up to you, but I'm happy to stay.
Thank you so much. Yeah, I don't know, Sarah, how many questions we have left, but why don't we finish the questions that are in the Q&A?
Yeah, there are actually two questions asking about the medications that are best. One says best for stabilizing emotions, and one just says common for people with BPD. So there's two questions like that.
Sorry, say it one more time. Something happened to my internet.
No problem. No, I was just saying there's two questions about medication, and one asks what's best for stabilizing emotions, and one just asks what's common for people with BPD.
Yeah, so for core BPD, in terms of, you know, the problem with using, if you use a mood stabilizer for bipolar disorder, that makes a lot of sense to me. But for people with BPD, the instability in emotions tends to be more of a reactivity to either stuff that's happening inside the mind, like, oh, you know, I'm being rejected, and then some sadness or anger, and it sort of more all over the place, or something that happens transactionally between the person with BPD and somebody else. And the problem is that trying to quell that with heavy duty medication, it can dampen down the whole emotional system, yes, but it will also dampen down cognition. It will also dampen down creativity. It's not just like it's going to dampen down emotions. If you want complete behavioral control, you can anesthetize yourself, you know, which is like, you know, like that's just too much. But so we're not looking for that. So I have not found for core BPD that any medication specifically helps. Now, because there's so much comorbidity, like someone that has PTSD, then medications like clonidine, medications, you know, some medications for sleep, to prevent nightmares so that people can sleep better. Yes, all of these can actually help a little bit, but not for core BPD. I personally, in thousands and thousands of patients, have not found a single medication that has reliably helped for core BPD. Certainly, yes, for comorbidities.
Thanks. As an adult with BPD, I relate to much of what you described as BPD in adolescence. What would you say are a few of the key differences in adult versus adolescent BPD?
Yeah, that's a really good question, and I don't actually know that there is that much of a difference, because when if I were to close my eyes and then just have the transcript of the discussion typed out, and all I could do was not see that I was speaking to an adolescent, but I was speaking to somebody with BPD, I don't know that I'd be able to tell the difference, except for a couple of things. The number of young people whose symptoms are magnified by the use of social media, and sort of feeling rejected, etc. Certainly self-injury is much more, and the levels of self-injury are much more severe and frequent in adolescents. We see adolescents being much more rapid in their switch with friends and partners and other things like that. But really, a lot of the core self-beliefs and things like that do seem to travel with them from adolescence through adulthood. So I would say, something about social media use and how it's being done, something about partners, and I think that the level of self-injury through cutting and other methodology seems different than adults with BPD.
Thank you. Another question is, how should one address the situation when a client exhibits signs of dysregulation following a year of treatment?
Well, so when Linehan developed BPT, she said do a year of treatment. But look, I'm going to be 60 next year, and I still show signs of emotional dysregulation at times. So what should we do? I do think that often we're not going to be these sort of, like, for lack of a better word, perfect beings. And we are perfect as we are already, which is like really remarkable that we're so perfect. And so the only question to me is, does the emotional dysregulation impact the person in adverse ways? And then I would want to know is, like, hey, look, you've been doing quite well for a year, and now emotional dysregulation is showing up. What's happened? What's changed? And sometimes circumstance, it can happen. Maybe there's a new job, maybe there's a new romantic partner, maybe there's an illness in the family. I'd like to know more about why that has changed. But the idea that we're not going to have emotions and that they're not going to be very strong is also, it's just like not something that we should like expect.
Right, thank you. So another question, complex PTSD can be misdiagnosed. How?
Yes. Yeah. So often what happens with complex PTSD is that somebody is sort of developing on a, maybe say, let's call it typical trajectory. And then they have very significant trauma in their life or series of traumas. And then what happens is that those, the memories, the flashbacks, the nightmares are so painful and so intrusive that then people want to quell those symptoms, and then they resort to things like self-injury, drug use, to tampen down the impact of the trauma. Now, what I see in terms of like some differences is that some of the attachment stuff and the interpersonal stuff is not as strongly there as with people with BPD. And what's actually interesting that whereas many of my clients with BPD will often talk about a strong desire for a connection with somebody else, often people who've had complex PTSD, who've had very traumatic experiences, actually do go the other way. They don't want to necessarily, sort of connect with somebody, because if the people I trusted most were the people who traumatized me the most, then actually I don't trust attachment and connection. So there's almost like a distancing. There's more of a mistrust of especially people who promise closeness. So I think that typically what I see is a typical developmental trajectory up until the time of when there's trauma, and then there's a lot of trauma symptoms, and then there the behaviors of self-injury, drugs, and other things are to quell the trauma symptoms as opposed to intense emotions.
Thank you. What about substance abuse, ADHD, and DBT? Which needs to be treated first? Not sure.
Yeah.
DBT, but yeah.
Yeah, and yeah. So look, John Gunderson used to say that always treat the thing that's going to, like, do the most damage first. So, for instance, anorexia, for example, is something that is very, very potentially medically serious, and also has a high mortality rate. So if somebody has untreated anorexia, that has to be treated first. Certainly, Marsha Linehan, used to try to use DBT with people with narcotic addiction, heroin addiction. Very, very difficult to treat. And so I think, to me, if there were significant substance dependence and a very strong substance like heroin, those kinds of drugs, and or severe eating disorders, and certainly untreated bipolar disorder, we would have a very difficult time using DBT in untreated bipolar disorder or psychotic disorders, because you need a certain level of capacity for reflection before you can do DBT. So if your central nervous system is like, out of control because of desperation for drugs, or it's not fed because of severe restriction and anorexia, or you unable to sleep because of bipolar disorder, or voices because of psychosis, those would need to be treated first.
Okay. What is a typical therapy route for BPD?
I was trained in psychodynamic psychotherapies, and I've now, as I say, I consider myself a DBT therapist. And for most people that I treat, I see that it's that somewhere, like, especially adolescents, within a year and a half, they're pretty self-sufficient, that they're pretty capable of managing most of the things in their life. That doesn't mean that they don't still need some sort of therapy and maybe some sort of supportive psychotherapy. So I would say the majority of people that I see probably sort of within a year. And then I have so much joy now because these days, remember, I started the program in 2007. So many of the young kids that I was treating are now older. I've been invited to so many weddings. I've been sent birth notices for kids. Three of my former patients I now refer patients to because they're therapists now, and it's just absolutely wonderful. They call me up and I think, oh my gosh, what's the crisis? And they say, no, I need consultation for one of my patients. So I think that what happens is that once somebody has
That's all. Paul, I'll turn it back to you.
Well, I have a few short announcements, but on behalf of everybody at Emotions Matter, we want to thank you, Dr. Aguirre, for your time and especially for your generosity in staying over to answer people's questions. I'm going to now put our post-event, let's see, I can get the survey. I'm going to put the survey in the chat right now. And, we do ask that, you'll get this survey tomorrow. Please give us your feedback. We had this presentation tonight because many people wrote to us and said they wanted more information about BPD and adolescents, which is why when Dr. Aguirre reached out to us and offered to do a presentation, we scheduled him. We are now in the midst of scheduling presentations for 2024. So please tell us what you would like to learn about, as we explore needs in the community to learn more about BPD and recovery. We always value the voices of our community members. So feel free to fill out that chat, the survey, which I'm posting in the chat, and you'll get that again tomorrow. You can also, for any additional resources or information for our peer resource guide, our free publications, which are stigma-free, in particular for those that may be interested with students of school age, we have our BPD in schools resource, which talks about how to advocate for school accommodations, which has been well received, and many other different publications. You can also go to our website for information about upcoming programs. And one I'd like to highlight tomorrow evening is, as I mentioned earlier at the top of the hour, we have a new director at Emotions Matter. We are delighted to welcome Joe Mancini to our team. And he'll be having a Zoom tomorrow night. And he's anxious and really excited to meet people in our community. So feel free to register for that event. If you have hopes and dreams for Emotions Matter, come and share your ideas with Joe. Joe would like to tell you a little bit about himself, but also hear about what you'd like to see as we build out our programs and platform for the next couple of years. And finally, in less than a month, we have Giving Tuesday coming up. This is the happiest time of the year for everybody, but also for us at Emotions Matter, because this is when we raise money to be able to provide low cost and no cost services to our BPD community. Programs like this are funded because of the generosity of our sponsors, which include McLean Hospital, where Dr. Aguirre is, and many other institutions around the country who support our work. But it's also because of donations. So our fundraising goal this year is to raise $100,000 between now and the end of the year so that we can sustain our peer programs for 2024. So feel free to check us out, follow us on social media so that you can be part of our Giving Tuesday campaign.